I hope are you expecting people to join?
Yeah. Some might join. A couple of them are already on Zoom, but I'm just going live for me. So hello and welcome to the podcast series Unpacking Decisions. It's a series on helping people make informed decisions and understand the nuances of a difficult topic and what are the consequences of it and how they can access support for shared decision making. The idea is that this will help them arrive at decisions that resonate with their priorities and improve their quality of life. Patients Engage is a platform that empowers people with chronic conditions and disabilities to engage better with their health and make informed decisions. We also advocate for more meaningful involvement of people living with long-term conditions in health system decision-making. I'm Aparna Mittal from Patients Engage, and I'm looking forward to the discussion today on vertigo, a symptom or a condition, in episode 6 of the Unpacking podcast series. Vertigo and dizziness is a common complaint, especially among older adults, and it greatly impacts daily life. It's a major risk factor for falls with severe long-term health consequences. And in common conversations, it is often confusing if vertigo is a symptom or a condition. Our guest today, Dr. Aditi Sinha, is an ENT specialist and a head and neck surgeon with over a decade of clinical experience across leading hospitals in Mumbai. She currently practices at Masina Hospital, Inlaks General Hospital in Chembur, Dhanwantari Hospital and Research Center, and Sanghvi JB Trust Clinic and Hospital in Mumbai. Her chief areas of clinical interest are deafness, vertigo, and allergy management. She's also contributed a 2-part article on vertigo for the Patients Engage community. We will also add, which has a lot of exercises, etc., which we'll be touching on in this discussion, but we'll add links to those articles in the comments. So Dr. Aditi Sinha will unpack vertigo, the causes and types of vertigo, how it's diagnosed and treated, what happens if you leave it untreated, and what can be done to prevent vertigo as well, and what can be done to improve quality of life. So we are also live streaming this. So if you post your questions on after the session, we'll try and address them. If you put them up during the session, then we'll try and capture them as much as we can during this, as we go along. So thank you, Dr. Aditi, for joining us today and for taking part in this Unpacking series.
Good afternoon, Aparna, and good afternoon to everybody at Patients Engage. Thank you for having me over. This is a topic very close to my heart because, every other patient we see comes to me saying, Doctor, I have vertigo. Okay. So I'm glad you've chosen something which is so relevant for people across age groups. It could be somebody who's young. It could be somebody who's 80 years old. It could be an athlete. It could be an actor. So I'm glad that we are discussing this today.
Thank you, Dr. Aditi. So let's start with what is vertigo, and is it a symptom or a condition?
Okay. So just like you told all of us in your introduction, vertigo is, to describe very simply, it's a subjective sensation where you feel that either your head is going round or your environment, everything around you is spinning or going round and round. But actually, all of it is stationary.
Right.
There is stillness, but you feel that you are in motion. So very simply, people say, "Mujhe chakkar aa raha hai." Chakkar is a very common terminology for this. And you'll be surprised as to even the most fittest people you see around you have spoken about this very openly. LeBron James, the basketball star, Hillary Clinton, Janet Jackson, and the likes. Even recently, Ayushmann Khurrana, the Bollywood actor, who's young, said that vertigo has taken over his life.
Right.
And as you asked me, is vertigo a symptom or is it a condition? Patients think that vertigo is a diagnosis. So they say that I have vertigo. But saying that I have vertigo is like saying I have fever or I have headache. It's a symptom.
Right.
And it is the sign of an underlying condition. What we need to know is, as you said, we need to unpack this. We need to know why you are having this symptom. So vertigo is a symptom, and we need to get down to what is causing.
Right. So, which means that you have to therefore understand the causes of it, right? And what
Yeah.
are the typical causes and risk factors of vertigo?
Vertigo is actually commoner than most of us imagine it to be, actually. Statistics say that 40% people say that they have had vertigo in their life. And even as we talk, people say that, almost 1 in 10 people are probably complaining of vertigo. So it's very common. Now, 5% of these people who have vertigo will have vestibular vertigo, which is, again, the commonest kind of peripheral vertigo, which brings me to, again, peripheral and central. So peripheral vertigo comprises of 80% of patients in the clinic who come with vertigo. So 80% is peripheral, as doctors call it peripheral, and 20% is central.
Right.
Peripheral would mean something which is related not to your brain and central nervous system, not to do with your brain, as in your big brain, your small brain, your spinal cord. So everything outside of it becomes peripheral.
Right.
And the commonest one among these is, again, a very commonly used word, which is BPP. Everybody says, I have BPP. And, when doctors don't care to explain, we just write those, that acronym. So I would want to talk about BPP first. It's a very long name, but it's about something very simple. So B stands for benign, P stands for positional, the second P stands for paroxysmal, and V stands for vertigo. So that's why we've just, compressed it into this. The name is self-explanatory. So benign means it's not serious, but it's very irritating because it can come at any time. Paroxysmal would mean, again, episodic. You will have it at some points in your life, some days in the month, and then you will forget about it. It'll come back months later, weeks later. If you're lucky, years later. And if you're luckier, they'll probably never occur. And positional means that when you move your head or neck or your eyes, there are extreme positions, is when you will feel this spinning. And V, of course, is vertigo. So this is the commonest form of peripheral vertigo.
Right.
Yeah. And the other peripheral causes would be vestibular migraine, basically vertigo which accompanies migraine. Then there is vestibular neuritis, labyrinthitis, less common, basically infections of the inner ear. Also cervical spondylitis. So if you're getting less blood supply to your inner ear, you could have a peripheral kind of vertigo. So these are the common causes. Also Meniere's. I forgot Meniere's disease. Again, something which you come across when you're Googling your vertigo. Not that common, but yes, that's also a cause of peripheral vertigo.
Right. Okay. So if these are the various types of vertigos, right, that you've talked of, and you've focused on the peripheral, vestibular peripheral ones, where does someone kind of come across the central ones? And, do they then kind of, and then we'll go into the differential diagnosis and which doctor to see. But if you can kind of give a little bit of an idea of the central ones, so that we can then go to that.
The central causes are 20%. And usually, at least I haven't seen anybody go directly to a cardiologist or a neurologist with that. So irrespective of whether your vertigo is peripheral or central, you're likely to approach your general practitioner, or your ENT will be your first point of contact, depending upon, your location, access to a specialist. And I think most of these patients move on to the next step, which is a cardiologist or a neurologist. Either if they are treated already, they become fine, or you get a referral where your ENT doctor tells you, you know what, this is not ear related. So that itself is your point to go to the next step. So your ENT doctor either tells you this is ear related and treats you, or they tell you that this is not ear related, is when you move on to the next step. Now, these are patients typically who will be either bedridden, the elderly, people with comorbidities, somebody who has uncontrolled hypertension, uncontrolled diabetes, a history of cerebrovascular accident, stroke, ischemic heart disease, thyroidism. multiple sclerosis, Parkinson's, dementia. So these are usually cases which come in the purview of people having central vertigo.
Right, right. So, and are there risk factors for peripheral vestibular? And are we focusing largely on vestibular peripheral vertigo?
Yes, I think we should, because that
Yeah.
comes more in the purview of ENT, and
Correct.
that is the simplest, most easily treated vertigo.
Right.
To say that central vertigo cannot be treated, but
We're talking today because we're talking to you and we're talking to an ENT
yes,
specialist, because for most of the central ones, you'll end up going to a
yes, and
neurologist or
also
a cardiologist.
50% would get sorted with your GP or your ENT. So
Right.
let's focus on what's common, and in that, let's focus on, as I said, the BPPV, the commonest of them all.
Right.
So there are predispositions. Okay, now to tell you the predisposition, it's important to know what is BPPV, what happens.
Right.
Again, a common word which patients have picked up is crystals. Doctor, I have been told crystals are moving in my ear. So these crystals are nothing but calcium carbonate, something which is in your body, chalky deposits. Medically, we again call it something like otoconia or otoliths. But to put it simply, they are crystals. They are crystals. And
Right.
they are in your inner ear. They may be set in motion. They're always there. Some people have more, some people have less. Older people, there's more calcification. Now, they are set in motion usually if there is an episode of head trauma, or there is an extreme movement of your head or neck. Something very simple would be yoga posture done wrongly. It could be you trying to lift something overhead, maybe from the kitchen shelf, something high. I have had elderly and even young patients going to the salon to get their hair washed backwards in the basement. And that's enough to set crystals in motion. And you come back with this, spinning, which lasts few seconds and it goes away. Okay. You'll also see it in patients who are very old or who are bedridden.
Right.
Where the mobility is not good. Turning in bed is something which sets it off. If you're very old, you just take a karvat, turn in bed, or get up at night to go to the washroom and it will get spin. So this is the commonest. These are the predispositions for this kind of vertigo.
Right, right. So if you look at, and you basically did say that, okay, so the question is, when should one see? Because in a way, people may even have an episodic, right? You have one incident of dizziness or spinning and it never happens for years on end. When do you advise people to see a doctor?
So I will not complicate this by telling you, medical algorithms. That's very tough. That's for clinicians. That's not for our audience. So to put it very simply, I would say keep these points in mind. So number one is, if you have acute vertigo, which lasts more than a minute, and it's a violent vertigo where everything is spinning so hard that you think you will fall. You vomit. There is extreme nausea. That's one. Two, if you have mild vertigo, but it's not going away. It's been there for a month. It's affecting your daily life. Rest, hydration, your usual home remedies, popping some pills over the counter. It's coming back.
Right.
So I would say something which is acute, something which is frequent, affecting your daily life, something which is lasting more than a month. I would want you to go to a doctor.
Right.
And, it's not for you to diagnose or say, oh, it's nothing. Let the doctor tell you.
Right.
The third thing I would say to look out specifically for ENT-related vertigo would be if your vertigo is accompanied with hearing loss, sudden hearing loss. You have tinnitus, a low-frequency buzzing tinnitus. You have oral fullness, like you feel that my ear is heavy. This is typical of male ears.
Right.
Or you have high fever, earache, ear discharge, then again a sign of vestibular neuritis, labyrinthitis. And it's amazing how you could just pick it up after a viral.
Right.
Not necessarily, you have a history of ear disease. Or viral could lead to labyrinthitis. So that's one thing. Central vertigo, again, if you feel that you have vertigo, which is accompanied with double vision, loss of vision, facial weakness, your mouth is drooping to one side, or you have weakness anywhere else in your body,
Right.
like the signs of stroke, or
Right.
splitting headache, which is not responding to aspirin or your usual medicines. A vertigo accompanied with a seizure. You have a fit, uncontrolled blood pressure, which is not coming down. So then these are signs, or let's say angina, you feel chest pain. Then these are signs that you have to go to the ER. Then you don't have to, then you go to the ER.
Right. 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 And if you go, so depending on, again, you've talked of different causes. So if it is high BP related, you'll eventually land up with a cardiologist. If it is stroke related, you could end up with a neurologist, and so on. But if you do kind of come to an ENT, what diagnosis or diagnostic process can you expect?
So as I said, even in these central cases, unless it's emergent, like the last few causes we discussed, people usually take their time. They'll get up for the next day to the GP or to the ENT. And it's, they're very scared because I don't know, the doctor's going to tell me so many tests to do. It's probably not even required and all of that. So the ENT examination is very simple. It's not going to take you more than 60 minutes. So it's a detailed history. What we are discussing, okay, your medical background, how's the vertigo like, how long does it last, your ENT checkup, your nose, throat. We check for nystagmus, which is basically movement of your eyeballs in the lateral gaze.
Right.
The ENT doctor will also check for basic central signs, whether you're not being able to coordinate properly. Are you able to do hand-eye coordination decently well? Are you able to walk in a straight line? That's called tandem walking. We check for Romberg's test, where you stand straight with your eyes closed. We see if you sway. So a clinical diagnosis as to what it is likely to be like can be done at your ENT. This is just clinical. And then, let's say another 15-20 minutes for your audiometry, because we need to know, especially if there's tinnitus, if there's hearing loss. So pure tone audiometry, simple painless procedure, takes 10 minutes. And impedance audiometry, another 10-15 minutes to check the pressure in your ear. And almost all clinics have it. Not even expensive. I think if you include an ENT consultation with this, would not cost you more than 5,000 in India. And then we do something which is called some basic maneuvers. There's something called the Dix-Hallpike maneuver. And to see whether, again, it's peripheral, central. So once you have a general idea of how it's going, if the doctor feels that no, it's not an ENT related cause, then we stop right there. You are referred to cardiologist for an ECG, 2D echo, and blood work, CT, MRI, MR angio also. But if it is an ENT cause and it seems clear cut, is when we do your balance tests, the postural tests, the equilibrium tests, which you would have read about.
Right. And you said it takes about an hour. Is there any?
This would take an hour. Not your advanced equilibrium.
Yeah, if you get sent off to cardiology, etc., then it's.
And even your equilibrium tests, then you need to come another day to do the other equilibrium tests, which are automated.
Right.
Your video nystagmography, your dynamic visual acuity, and the advanced tests.
Right. And are any of these uncomfortable? Because you may have a person who is cognitively impaired, and you're trying to figure out how to bring them in, because it's difficult for them to manage, and it's also difficult for their family member to.
Actually, for a cognitively impaired person or somebody who's bedridden, bedside examination, a thorough history, even a simple caloric irrigation of the ear with warm water, cold water. That's a very age-old test, warm air, cold air, can be done at the bedside. The worst that can happen to you is that you feel a little uncomfortable. You just feel a little dizzy for a bit and it will settle down. But apart from that, is there any hazard? No. The basic tests can be done at the bedside. All audiometry tests can be done at home. your impedance, your pure tone audiogram. Yes, of course, for imaging, X-ray can be done at home, but that's if it's your spine. But for advanced imaging, you'll have to take an ambulance, wheelchair, and use.
Right, right. So, we've talked of what is vertigo, we've talked of kind of the diagnostic process and the tests involved. What are the current treatment options? Are there options for people as medications or exercises or those maneuvers? Or what are the treatment options?
So with vertigo, there's no either or. Okay. A lot of patients say, doctor, I'm eating my tablets. Or there are patients who say, I don't want tablets. I just want to do exercises. Or I will first take the tablets and then do the exercises. Or when exercises fail, then I'll eat tablets. So it doesn't work that way. Vertigo can be cured. It can be managed depending on what kind of vertigo it is. And we can help you decrease the frequency of your episodes. We can help you decrease the severity of your episodes. And if it's something we can completely change, then we can cure you of it also. So there is this myth, hey, vertigo, hey, I have vertigo, I have to live with it. No, you don't. And there are medicines, yes. So it starts, of course, with the diagnosis, and then we give you anti-vertigo medications. Again, I would urge people not to use over-the-counter medications for chakkar. So you start off with compounds like beta-histine, cynarizine. You have a whole repertoire, okay, that's available. Sometimes because vertigo causes anxiety, it causes insomnia, you may be put on anti-anxiety medications. You may be put on something which helps you sleep better. But usually we give these medicines for a period of time where you learn how to manage your vertigo. They're not going to be lifelong. So you have to remember, I won't be addicted. I won't be dependent. I'm going to go off them. And yes, along with it, there are going to be supplements. So there would be something like, say, vitamin B12, B6, zinc, alpha-lipoic acid, ginkgo biloba, antioxidants, which we give you to supplement this therapy. Yes, if you have labyrinthitis, vestibular neuritis, which are ENT emergencies, you may have to be admitted. You have to be given IV antibiotics, oral antibiotics, but usually it's not required. Then there is supportive therapy in the form of lifestyle changes. That's also part of the treatment. Very important. And extremely overlooked. Extremely overlooked. So everybody wants a quick fix where, I'd rather be on the pill. I can't do all of this. But you have to do all of that. Which
We'll
would
come to lifestyle changes. Can you first just look at, I want to understand what is the role of supplementation. If you can kind of talk on that. And are exercises part of the lifestyle changes, or you want to cover exercises first and then we can talk into?
We can cover them together. Okay. So supplements, right? So supplements are basically given as supportive therapy, because often we believe that inner ear free radical damage or neuropathies, vitamin deficiencies. Vitamin D deficiency is known to cause vertigo. Osteoporosis is known to trigger vertigo. So we give this along with all of this. We can't reverse the damage, but we try to halt the damage. So very often I have put patients on anti-vertigo medications. The acute vertigo has subsided and they are continuing with their supplements. And these are specific to neuropathy, specific to the nerve. It's not your typical B complex which you are having. And so you feel that I'm having my B complex, I don't need this. Or I'm having my calcium and this is something else. So this is important.
Right. Okay. So if we come back to then the supportive care, if you talk about the exercises and the lifestyle changes.
Okay. So lifestyle changes would begin with, number one, if you are on any sort of dependency to any kind of other medication, which you're not telling your doctor about, or any kind of drug, are you dependent on alcohol, tobacco intake, then that is something we have to look at. Because that could worsen your vertigo. I'm not saying that that is the cause, but that could worsen it, that could accelerate your vertigo. So we have to look at probably quitting that to increase the amount of course, vitamin A, vitamin C, antioxidant-rich food, which could be green leafy vegetables, berries, nuts in your diet. The third would be stop living a sedentary life. So many people who have vertigo become increasingly sedentary because they think every time I move, I'm getting vertigo. And that worsens their situation. Postural problems, increased screen time, very bad posture in the office where your table and desktop are not aligned. All these are triggers for vertigo. So you need to be mobile, you need to be flexible, and you need upper body strength. Upper body strength is something we don't focus on. We focus on running, right? Running, cycling, So head, neck, shoulder strength, especially for women.
Right.
Women, post-menopause, osteoporosis. You have C5, C6 spondylitis, the commonest cause of vertigo, which can be easily corrected. So yes, these lifestyle changes, yoga, meditation, anything that helps you de-stress.
Right.
But again, tailor-made. I do not want you to be doing mass yoga, which is probably worsening your vertigo. So that's important. Yeah.
Right. So you also mentioned, say, take alcohol, right? If someone is a occasional drinker, say a glass or two of wine on the weekend, is that a risk factor for them if they have vertigo?
It's not a risk factor for them, but usually anti-vertigo medications, anti-anxiety medications do not mix well with alcohol. So we tell you to be off it at least while you're taking it. Sometimes you might be put on a muscle relaxant. Now that doesn't go very well with you having consumed alcohol. It could be a deadly cocktail. So we say, okay, just be off it while you're on therapy. I'm not saying you have to quit it. Yeah.
Right.
Sorry.
Go ahead.
Advisable to, be off it.
Right. And how long do people need to be on anti-vertigo medications? Because you said it's not lifetime, but is there a kind of time duration for that treatment? And then do they have to come back to it every time they have an incident? How does that work out?
So as per the FDA, beta-histine 24 mg could be given thrice a day for a year. So that's safe. But that doesn't mean we give you that for a year. What I'm trying to say is that the safety margin is high. You could need to be on medication for a year if you do not bring other things into place. And people take a very long time to change their lifestyle.
Right.
So what happens is that the minimum time you need to put them on the medication for would be a month, usually.
Right.
Unless, again, it's an infective cause or some head trauma or something like that, which is correctable. And 1 month of tapering medications, seeing how they are faring. You can't start and stop it because then you get a rebound vertigo. So it's important to taper as per your doctor's advice. And as you begin to taper is when you step up your lifestyle. The medicines keep coming down and you keep improving your lifestyle. So that there is a culmination by the time you finish your medication, you're already on the path.
Right. And what is the role of things like Epley maneuvers?
So, yes. Now, the thing is that Epley's maneuver is used mainly for BPP.
Okay. Right.
There's a maneuver called the Epley's. There is a maneuver called the Simon's maneuver. Check it out. Now, how often are they done? Are we really doing it? Yes. Sometimes we need to do these maneuvers. They can trigger extreme vertigo when you are doing it soon after. And the good part and the bad part is that BPPV would go away on its own also, in weeks or months, even if you do nothing, because the crystals either dissolve or they settle down. So very often we choose not to do the maneuver. We give you supportive therapy and we do not want to put you through that. But sometimes if the vertigo is very acute, the patient is in the clinic, needs a quick fix, or I feel that the patient is very old, cannot keep coming back, cannot wait that long for it to settle down, dissolve, may have a fall, especially the elderly people, debilitated people, they may have a fall because of this. Now, expecting them to wait for it to go off on its own, the simple thing is to diagnose the vertigo, do the simple maneuver, give them some supportive medication, let them rest, be okay, and go home. So
Right.
that's the quicker way of just making the crystals settle down.
Right. Right.
But do we choose to do it in everybody? Probably not.
Right. Right. And how does one identify the triggers for your vertigo, right? So you've said all of these supportive things, and you said it could be, I mean, they're all not great for you, right? If you have alcohol, if you're a smoker, etc. But is there a correlation in terms of them being triggers, and can somebody, are they supposed to maintain a diary and say, okay, when I do this, then it causes vertigo? Is
Great
there a
if the patient
correlation?
could do that or the caregiver could do that. Because, as I said, it also goes hand in hand with migraine very often. So we ask our migraine patients to maintain a diary. So similarly for vertigo, what could trigger vertigo in me may not trigger vertigo in you. Like some people they have motion sickness, some people don't. So it's ideal if the caregiver or the patient could write it down, say that, hey, when I have all of this, I feel it's triggered or it gets worse. Now, common things we've discussed, it could also be high caffeine intake. Sometimes if the caffeine intake is high or you're overhydrated, this water therapy, having 3-4 liters of water increases pressure in your urine. High sodium food. Generally after a party, you had these salty snacks, alcohol, could be a trigger, the next day. For vertigo. So good to maintain a diary, yes. But most patients default. So it's a big ask.
Yes.
Yes.
So I want to come back to that because I don't think people understand when you said just now the water relationship. So can you kind of highlight that once more of, clearly
Sure.
what is the relationship on that?
So see, vertigo is related to the inner ear, the peripheral ear. The inner ear has fluid and it has salt, like every other part in the body. And wherever there is more salt, the body pulls in water. And the more the pressure in your inner ear, the more likely you are to get into an episode of vertigo. Now, a lot of people are watching videos, doing hydrotherapy, Ayurveda, and all of that. But you have to make sure that it is working for you. It is tailor-made for you. And it is not a generic advice. So what happens is when you're already hypertensive or a heart patient or a kidney patient or simply a vertigo patient with none of this, and you are getting up in the morning, putting 3 liters of water in your body, plus having your tea, coffee, juices, soups throughout the day, there's a fluid overload. And that is a very, very common trigger for vertigo, very common trigger for Meniere's disease. So there's something called a Meniere's diet, which people could, read up on after this talk. So if you have Meniere's disease, there's this Meniere's diet, where we say, no, you are not going to have more than 8 glasses of fluid in a day, which includes your tea, coffee, while you are having this Meniere's. You're going to cut down on tea and coffee. You're going to cut down on sodium. And when we say sodium, it doesn't mean khane mein kam namak. Don't put less. Of course, you will use less food and salt, but hidden salts, which nobody's talking about. Your chutneys, your pickle, your papad, namkeens, packed foods. So they are having all of that. And that has to be, again, addressed.
So I'm a little conflicted, right? So on the one hand, you're saying that migraine and vertigo go together. May go together. And migraine often, or one of the triggers for migraine is actually dehydration.
Yes.
But for vertigo, it is fluid overload.
Yes. But the thing is, every vertigo is not a migraine as vertigo. So you need to know. Migraine could be triggered by, sunlight, hunger, chocolates, teas. So you have to know what kind of vertigo you have. That's why I said it's a Meniere's diet. It's not for you if you have BPPV. It's not for you if you have spondylitis. So a diagnosis is very important.
Right. And so coming back to, you've said that we've talked of treatment options, we've talked of lifestyle changes. What should people be doing to improve their quality of life?
Okay. I think this would apply to people across age groups. Also, I think it would apply to you even if you didn't have vertigo. So, most of us know what to do, but we don't do it. As I said, even then, stop being sedentary. Get up and move. Whether you are in your office, cut down on your screen time. You need to take frequent breaks. This is for younger people, of course, who are at the workplace. For older people, again, there is this fear which we discussed that now I have vertigo, so I have to just sit still. I cannot move. I should stop exercising. I should stop doing anything. No, that's not the case. Yes, when you have acute vertigo, your doctor is going to put a lot of restrictions on. We are going to say, no, we don't want you cooking. We don't want you traveling alone. We don't want you driving, swimming, diving, taking a flight, the common things. But otherwise, it is important for you to strengthen your upper body. So daily exercise, again, it has to be tailor-made. So daily exercise, upper body strength, head, neck, shoulder, very important. For older people, again, hand-eye coordination is something which they are not doing because they're old, but they have to get back to doing it. So it could be simple things at home. It could be, you could play something like TT, something which is not a very high intensity sport. Or maybe just simple ball exercises while you are sitting. So even, I don't want you to say that, okay, doctor, I've had a knee surgery, I can't get up. Yes, you can sit on a stool and do ball from one hand to the other. Or your pen exercises where your gaze follows the pen. So these are simple exercises which you can do at home. You can do in the hospital. You can do in any location in the world.
Right, right.
That's important. And yes, breathing, meditation, because anxiety is a huge trigger for vertigo. In young people and in old people. I mean, their anxieties are different, but it's a massive trigger.
Right, right.
And when you're anxious, you are doing more of junk food eating. You're also doing more of drinking, smoking, and all of that. So it's a vicious cycle.
Right, right. And when you kind of emphasize on upper body strength, you're linking it essentially to vertigo caused due to cervical spondylitis, or there are even a BPPV could be
BPPV too. BPPV too. Cervical spondylitis, you'll of course have very specific exercises for your neck. But what usually happens is that when your upper body is weak, it is not able to take the weight of your heavy head. And this is not a part of your body you regularly use. And these vertigos, peripheral vertigos, are triggered by change in position of your head and neck. Because they are triggered by this, you stop moving this.
Right.
It gets stiffer, this gets worse.
Right.
And this is, the upper body is a neglected part. So the stronger this is, the less chances of your vertigo coming back. And it has to be a way of life. Patients become all right and they stop exercising. They say, now I don't need to. And they will come back to you after 3 and 6 months and say, doctor, when I was doing my exercises, I didn't have vertigo at all. And then you just have to say that, then why did you stop? But then I was okay. So this has to be a way of life.
Right, right. And you also said that, is motion sickness kind of correlates with people? So if you have motion sickness, are you at greater risk
Not
of
really. Not really, no.
Okay. So exercises, as you said, are important. Are there exercises that you should not be doing?
Okay. During an acute attack of vertigo, I would not even ask you to do these exercises, which are your rehab exercises. It has to settle down. A lot of people are keen to not stop or start off with exercises soon, but you have to balance it out. Only when it's the vertigo is less severe, less violent, as we say, is when you gradually start with it. So there has to be a fine balance. You have to not do things like headstands, burpees, jerky exercises, overhead weightlifting, for example. Very heavy weights, if you're used to doing them in the gym. I would even say do not run on the treadmill, because if you have vertigo and your treadmill is on, it can be dangerous. So cycling would be safe, or you use a mechanical treadmill or a mechanical cycle, not your automated. Because we see, nobody really dies of vertigo, right? Nobody, I mean, very rarely do you end up in hospital because of vertigo itself.
Right.
It's usually a fall.
It's the fall. Right. Right. And fall is a big predictor of, quality of life and decline especially as we.
Absolutely. For the elderly, it's almost, as they say, it's a death sentence, because if you fracture your hip, or there is bleeding in your brain, it's very difficult to come back.
Correct. So, you also talked of, anxiety, that, people may have anxiety and that's a trigger factor, but also when you get diagnosed with something like this, your anxiety levels go up, or the family members kind of get overly protective and restrictive. So again, what's your advice to the person with vertigo as well as their family members?
So the first most important thing is that if you have somebody who has vertigo in your home, a young person, an elderly person, please accompany them to the doctor. Do not send them alone, because vertigo cannot be managed just by the patient themselves. And the commonest thing is, in a mobile patient, is the patient coming to the OPD alone. So the role of the caregiver here, as you said, is equally important. Sometimes the caregiver is too scared, or they are too casual. So both things do not work.
Right.
You cannot restrict that person from doing their daily activities. Because when you do that, it's a vicious cycle. That now I'm no good, I can't do anything, I can fall anytime, I can die anytime, anything can happen anytime. Most vertigos are not that sudden. You will know that the vertigo is coming on, like a migraine. If you had BPPV, you know what's triggered. Don't do those movements. So most patients themselves know what their triggers are, usually.
Right.
And they know that BPPV lasts a few seconds. So a fall with BPPV is rare.
Okay.
Usually the patient tends to sit down, or it's just for 5 seconds, and then they are all right, irrespective of them having taken any medication. But as you said, they get anxious because they think it can happen anytime. What if I'm in the market?
Right.
What if I'm walking down alone? And that is why family members say, okay, stop doing all of this.
Right.
So then again, you have to talk to your doctor. You have to talk to your physio, rehab person. When they give you a clearance that, okay, these are the activities you start with, and when you're able to do these safely is when we go to the next step. You can't start with driving. You can't start with going to the market alone. You'll start with doing your daily chores at home. Once they are safe is when you move ahead.
Right.
And anxiety, even in caregivers, is massive, because there are people whose parents are home alone. They are at work. They don't know what they should do. So as I said, keep emergency medications by the bedside. You're turning in bed, you feel something, there is a medication you take, right? Install handrails, anti-slip mats. Tell them basic things like, don't lock the bathroom when you are going in for a bath.
Right.
Keep the phone near them. And
easier to say than to have them
they
agree to.
Old people would not even want to use a stick.
Right.
They come with acute vertigo, but I'm not going to take a stick or walker. So it's hard. Yes.
Yes. So, and are there any, obviously there are restrictions that they apply to themselves. You mentioned driving, and you mentioned exercise,
cooking, even cooking. You don't want to go to the kitchen.
Right.
Traveling. They don't want to travel to any place.
Right. But once the episode is over, then you can, or is there?
Yes, of course you can. Yeah, of course you can.
And are there any medical restrictions that swimming is allowed?
Swimming is a no-no. Swimming, diving, air travel. Yeah.
Right.
Yes.
Right. Can vertigo be prevented ever? As in, I don't ever want vertigo in my life. Is that possible?
Depends on what the cause of vertigo was.
Right.
So BPPV tends to keep coming back. As I said, if you're very lucky, then you'll have just one episode of it in your life. Meniere's tends to become a lifelong condition if not managed well. And the most troublesome aspect of Meniere's is not the vertigo, but it is the loss of hearing, which is very. But otherwise, if you correct the underlying cause, if it's due to vitamin deficiency, if it's due to BP, due to thyroid, due to anything which is correctable, of course you can prevent it. from coming back. But if your
Right.
question is, can I never have vertigo if I've never had before? Is that your question?
That also was my question. Yes.
So that's so that's a tricky one. Of course, as I said, after the age of 55, you are more likely to have vertigo in your life. So it's like aging. You can expect it to happen. You shouldn't be alarmed because, as I said, 1 in 10 people will have it. Women tend to have 3 to 4 times more vertigo. So yes, these classes of people, we can tell them that, okay, you know what, take your supplements, do your exercises. That is all the preventive thing can be about.
Right. Right.
But comorbidities and age usually does catch up.
Right.
It's hard. Yeah.
And are there any medications or conditions due to which vertigo is especially the peripheral vestibular vertigo is a side effect or a consequence?
There are drugs known to cause vestibular toxicity, ototoxicity. Aspirin, long-term use is known to do it. Streptomycin, if you've had tuberculosis in the past, is a vestibular toxic drug. But usually, these cases are rare, Nowadays, doctors are also very aware and patients are also very aware. So unless you've really taken injections like streptomycin and things like that, it's a rare case of drug toxicity that we see.
Right.
And it can be managed. I mean, we can stop the drug and it's easily managed, reversible.
Right. And what are the consequences of not properly diagnosing and treating vertigo?
Okay.
And especially in India, right, where people
question.
can just talk to each other and figure out a medication or go to the pharmacy and get something.
So that's why. So that brings us to the common myth that once you have vertigo, it never goes away. It never goes away because you never go to the right person. And then you think that it is something which is going to be a part of your life and you stop doing anything about it increasingly. When you've had it for a month, then you've had it for 6 months, and then you think, now what's the point? Right? So it's sad that this happens because a lot of OTC medications are available. And, they have typical names also. So, that makes you understand that, okay, this must be for the vertigo to go away. So, they are marketed like that also. And you go to the pharmacist, you buy the medicine, you take it as and when you want. They don't understand that very few vertigo medications are SOS medications. They're all long-acting. Unfortunately, in India, a lot of general practitioners choose the wrong combination of drugs. Or they give you a mix of 3-4, all of which are probably cancelling each other's effect. They're all vertigo medications, but acting on different chemicals. So then again, they are not working. So you're on 4 drugs, you're not becoming okay, and you think, obviously, this is not going to get cured. But then that's again a myth. The third thing is not giving a medication in the right dose. Again, very common in India. Even for fever, even for antibiotics.
Right.
Self-dosing, wrong dosing, and then this despair that it's not working. Or taking vertigo medicines for 5 days, suddenly stopping them, feeling okay. This gap of another 5 days, and there's a bad rebound. So yes, diagnosis is very, very important, and the correct dose and the right choice of medication. It'll differ from somebody who's an elderly person, a young person.
Right.
Maybe we could give something which is mildly sedative to somebody who's at home, but I can't give it to a young person who has to go for work. So the choice of medication is also very important. So yeah, I mean, self-medication, self-diagnosis, not just with vertigo, I think with any condition is something we should highlight and ban.
And you did touch on a little bit of screen time as well, and the weight of the head. Among the things that you advise people not to do, would that also include phone usage?
Yes, screen time would mean phone usage primarily because work screen time is not totally under your control.
Right.
And most people are using the screen for work. So when they come home is when they have their recreational screen time. So it's double the screen time. There are very few professions nowadays, maybe, like doctors who don't use the screen so much. So the only screen time we have is recreational. But
Right.
say for somebody who's working in the office, it's double, right?
Right.
And the smaller the device, the smaller and the more you scroll, of course, there's fatigue in the eyes, and that's a very big trigger. Bright lights before sleeping. You're not able to sleep well. You wake up next day with a migraine. You wake up with a vertigo.
So yes, I mean, I think there is people do understand the correlation between not sleeping well and migraine, but you're saying there's a correlation.
Yes,
to
absolutely.
vertigo as well.
Absolutely. Yes, yes. Anxiety, lack of sleeping, screen time, less talked about, but big triggers.
Right, right. Okay. I think those were all the questions that I really had at this point. Anything else that you would want to? And I think we covered a couple of audience questions also.
Okay.
Any other points that you would want our audience to know?
Do you want me to? There's another condition I think I would want to talk about. It's a chronic vertigo. We have talked about these things which get sorted easily, within say a month. But when your vertigo lasts over 3 months, there are times, and that is a condition which is almost the opposite of BPPV. And somehow I think it's not being talked about. It's called persistent postural perpetual dizziness.
Oh, wow.
It's,
just reinforcing that it's chronic.
That it's chronic, yes. And it's a vertigo. It's basically, it's not just spinning, it's unsteadiness, gait imbalance. It'll give you a picture very similar to a central vertigo, something that's not responding to your usual medications, right? And patients have assumed it's a way of life because it's been there for 3 months. And again, it's also postural, it's perceptual, and as I said, it's persistent. So this could be, again, a chronic vestibular dysfunction, something chronically wrong with your inner ear. It could be due to your mean ears, which wasn't treated. And that's why it's become a chronic. It could be untreated vestibular migraine causing this. Also like vertigo, migraine also becomes a part of life. You would say, patients say, I have migraine, I know what to take, and it becomes okay. Half a day goes waste, and then I'm fine. So this is what I wanted to talk about. And
so is there treatment? Is there specific treatment available for chronic vertigo, or
the treatment lines are the same? I just feel that most vertigo will not become this if you go to your doctor sooner. My point was that do not wait for a vertigo to last beyond a month, because it can be treated again, but we start with the same battery, and your timelines for feeling better will be longer.
Right.
Because your body's gotten used to this.
Right. So you're saying that you could start with, say, BPPV, and it could become chronic if you don't treat it properly.
Yes. Yes. I'm trying to say that most vertigo is treatable, but timely and correct intervention is important. Right.
Right. Okay. And so you've talked of chronic. We've talked of the different types of vertigos. We've said who you need to go to see, when do you go to an ENT and when do you go to a cardiologist or a neurologist or a GP. We've talked of treatment options, importance of diagnosis. We've talked of management of quality of life and, lifestyle changes. Anything else that what's your final words to the audience out there?
Okay. So just sum it up, I would say what I say to my patients, that again, it's coming back to where we started. That your vertigo, when you come into me and telling me that you have vertigo, the first thing is it's a symptom. It is a symptom of an underlying condition, of a treatable condition. So there is hope.
Right.
That's where we start. Accurate diagnosis, targeted therapy, done at the correct time, can improve your quality of life. It can decrease the severity of your episodes. It can even eliminate vertigo from your life. So 4 Ds is what I will say.
4 Ds.
4 Ds. Okay, these are my 4 Ds. I mean, they are not written.
Yeah. Go ahead.
So the first is don't self-diagnose and self-treat.
Right.
Don't delay.
Sorry?
Don't delay. Don't
Don't
delay
delay.
seeking.
Right.
And the third is don't discuss and be in despair. You keep checking with me.
Right.
How do you feel? When did your vertigo go? Or what is your diagnosis? Don't do that. And the fourth, don't be depressed. Have something which can be easily diagnosed, equally easily treated, but you need to get up and go.
Right. Okay. I think with the 4Ds, you've kind of summarized it really well. So I think to our audience out there, it's quite clear that, vertigo is a symptom. It's not a condition. So don't just say, I have vertigo. As Dr. Aditi said at the beginning, that's like saying I have fever. You need to find out the cause. You need to figure out the diagnosis and get it treated. And I think the other key thing really is that, you don't have to live in fear. If you have vertigo, it is treatable. You can return to your quality of life. It will be you'll have to make lifestyle changes. So I think that's something to also remember, that, you can't say, okay, now it's gone and I'll go back to doing and I think that's something that is not unique to vertigo. It's just, I think, as more and more we are finding out that lifestyle changes means that you have to hold on to those changes for life, right? And that's what it is. So you have to keep those good habits going. I think the key learning for me was really that focus on upper body strength. You don't think of it, and also you don't think of vertigo as this positional thing and postural thing, which kind of causes all of these incidents. So I think that's a huge takeaway. As I said, we will also add in the comments and in the show notes the links to Dr. Aditi's articles on Patients Engage on Vertigo, which also has images of exercises, etc. And if you write into us, I'm sure we can address any other questions as well. So thank you, Dr. Aditi, once more
Thanks,
for
Aparna.
joining us today. And thank you to our audience for being there. And don't forget to subscribe to our channels. Thank you.
Thank you. Bye-bye.